right, everyone, we'll go ahead and get started on chapter 32. This is over orthopedic injuries. Yes, I agree that looks like it's spelt weird, but that's the way it's spelt. And so this chapter is going to be covering obviously bone injuries, like musculoskeletal injuries. And so we'll go ahead and get started. And so the musculoskeletal system provides, it provides this form of our body. Like it allows us to have upright posture, movement, right? All of these work together. It also provides us protection, okay? And so it protects the vital organs and the internal organs. So with that said, they're not invincible. And so bones, muscles, tendons, cartilage, and ligaments are still at risk of injury. And so we'll talk about what those injuries are, and we'll talk about the difference between a fracture, sprain, strain, dislocation, all of those things, okay? And so musculoskeletal injuries are among the most common reasons why patients seek medical attention. As if you've watched this, if you're watching this video, maybe you've broken a bone before. So it's fairly common for people to break bones or dislocate joints or whatever. And so often easily identified because of the pain. The patient will have a pretty good pain with fractures, and we use a word called point tenderness, to where you could ask the patient to point where it hurts the most. So I'll tell the patient point with one finger and one finger only where it hurts the most, and they'll usually point at like exactly where the x-ray is going to say it's fractured. And then this can result in short or long-term disability. So for example, like a broken pelvis is going to take a lot longer to heal than a broken toe. And so it kind of depends on the location and the severity of the fracture. Along with the patient's underlying health, so blood flow and general health and activities before and after the fracture, those all contribute to the recovery time. And so this is tested. There's three types of muscle, okay? And so these first two are in their own group called striated. And so the reason these are called striated because they have striations in them. And so skeletal muscle and cardiac muscle both have striations, and you can see that here in this pattern. You can see that there's like striations in the cardiac muscle and striations in the skeletal muscle, okay? And so that is called striated muscle. And then the other one is smooth muscle because it does not have striations and it's smooth. So examples of where smooth muscle would be like in the bronchioles. This is why we give albuterol, to relax the smooth muscles. We also see smooth muscle in the vessels. You see smooth muscle in the uterus. Those are you have smooth muscle in the bowels, in the esophagus, parts of the esophagus. So there's smooth muscle really on the inside of the body is where you're going to find that. Now, skeletal muscle is going to be more of the external body, right? These are your muscles, your biceps, triceps, quadriceps, gastrocnemius, abdominals, right? Obliques. So these are the skeletal muscles, and these are striated, okay? And then cardiac muscle sounds like what it sounds like. It's found within the heart. So we only have cardiac muscle tissue within the heart. Now, of the heart, what do we call that tissue? What do we call the heart or the muscle tissue of the heart? The myocardium. The myocardium. Okay? And so skeletal muscle attaches to the bones and usually crosses at least one joint. And so an important concept to know is that when muscles contract, they get smaller and they ball up. And so when you flex your bicep, you're flexing the bicep because the muscle in there is getting smaller and it's squeezing together. And so that is what, if you were to flex, that's what you're doing. And so that's a concept to know that I've talked about a lot with the diaphragm. But when muscles contract, they get smaller, and so they have to connect one bone to the other. It wouldn't make sense to pull tension on a single bone. So, for example, back to the bicep, it's connecting the ulnar radius to the humerus, and so this is causing a flexion motion, okay? And then the triceps is doing the opposite. It's causing extension, okay? Connections at the same bones, but that would be the example. And so these are also called voluntary muscles. Why is that? Because skeletal muscle is the one that you have control over. So you don't have conscious control over your heart and the muscle activity in there. You don't have conscious control over the smooth muscle in the uterus or in the bronchioles. And so this is skeletal muscle is is controlled by your thoughts. You can control this. Now, someone would say, well, what about the diaphragm? Isn't that skeletal muscle? And I don't think about that. You're right, you don't, but it does require innervation. Like it requires your brain to be thinking about it. It's just not in your conscious thought to breathe. But you can override it and have a conscious thought of breathing, right? If I were to say take a deep breath or hold your breath or breathe faster, slower, you could do that. But if you stop thinking about it, even for just a moment, your body will take over and breathe for you. Okay? And so all skeletal muscles are supplied with arteries, veins, and nerves, and that's what they're showing you here. So this is a nerve, then there's an artery coming into it, and then a vein is leaving it. Okay? And so all muscles have that. They have to have that. Okay, because muscles don't know what to do, so they have to be told what to do by the brain. And so that message is sent to the muscle by a nerve, usually a group of nerves, right? And so skeletal muscle tissue is directly attached to the bone by tendons. Okay, students get this confused all the time. Okay, so it's tendons that connect muscle to bone. Okay, tendons connect muscle to bone. So smooth muscle, like I said, this is, you obviously have this in the lumens of the vessels, you have this in the uterus and the bronchioles, and this is going to be stuff that's inside the body, okay? So we don't have any control over the muscle on the inside, the internals of our body, and any conscious control, I should say. And so these work automatically, okay? And so usually, like, where we'll see this is like, it's not all tubular structures, but they're usually tubular in shape to where when the muscle constricts, it'll clamp down on the lumen of something. And so you could even imagine the same thing of the uterus. When the uterus constricts, it clamps down to expel a baby. And so, that's the idea of smooth muscle. Now, cardiac muscle, it has its own involuntary, it's involuntary and it has its own regulatory system. So what does that mean? What this means is even if you were to decapitate it, right? Like someone chopped off your head, your heart would still, for at least a couple seconds, try to do what it's supposed to do. Okay, and so that's because it doesn't really need the brain per se to. There's cardiac escape phenomenon to where the heart will try to do what it's supposed to do as long as it can. And so the cardiac muscle is involuntary, and it does have its own regulatory system. Okay, and so the skeleton gives us our recognizable human form. It protects our vital organs. It allows us to move. It's made up of approximately 206 bones. Now, an important thing to know is that those other ones are obvious, but it produces blood cells. And so within the channels of bones, there's something called marrow. And so it's this fatty substance that its job is to produce blood cells. Okay, and so red blood cells and the beginning of white blood cells are all made here within the marrow. Okay, and so with that, the bones itself serve as a reservoir for minerals and electrolytes. So could you imagine which electrolyte is most abundant within the bones? It is calcium, right? The bones are majorly, pretty much calcium. It's calcified. It's hardened calcium. Okay. And so when your body needs calcium, it sends these little Pac-Man guys into the bones that'll chew on the bone and release some of that calcium into the bloodstream. So that's how that works. So again, it's 206 bones. One thing I'll point out here is the things they have painted blue on here is cartilage. Everything else is bone. And so there's cartilage that holds together the pelvis. There's cartilage in the fibrocartilage disc between the vertebra. There's cartilage that connect the ribs to the vertebrae, or to the sternum, excuse me. Okay? Now, the skull protects the brain, the thoracic cage protects the heart, lungs, and great vessels. The pelvic girdle, or the pectoral girdle, excuse me, consists of the two scapula and the two clavicles. And I think that's, yeah, right here. And so the scapula is this big triangular bone on your back, okay? And so it drives me bonkers when people are listening with their stethoscope and they're listening over the scapula. You're listening to a bone. And there's very few instances where that's indicated and useful, but you're listening over a bone, so you should listen somewhere other than over this big triangular thing on someone's back. And so the pectoral girdle, this area right here, really does a good job protecting some of these organs because you have protection from the back, from the scapula. This is looking at the patient's back, and this is looking at the patient's front, the anterior view. And so, and in the front, you have the sternum and the ribs and the clavicle and the humerus. And so even the humerus, to a degree, protects this whole area. It's pretty well protected by bone to protect some pretty important stuff, i.e. the heart and the lungs. Okay. Now, the upper extremity extends from the shoulder to the fingertips. It's composed of the humerus, which is this long bone right here. And then the elbow is a connection between the humerus and the radius and ulna. And so if you were to hold up your hand and I say, student, which side is the radius on? It's the thumb side, because remember, we check the radial pulse on the patient's thumb side. And so that the radius runs on that side, on the side of the patient's thumb. Okay? You can see that here in this picture. There's the radius. So the hand contains three sets of bones. So there's the carpals, metacarpals, and phalanges. And so the carpals are really your wrist bones, okay? And so there's a lot of different ones in there. One that is a little bit of interest is the scaphoid because this tends to get broken on fall on outstretched hands. Okay, so you can break that pretty not easily, but commonly. And it's the junction between the radius and the scaphoid. The radius will push through that and break it. Okay, so the carpals are the wrist bones. The metacarpals are the hand bones, and the phalanges are the finger bones. Now, something to know, these are pretty intuitive, but the thumb, index, long, they do call it the ring finger in medicine, and the little finger is known as the pinky finger. Okay? And so the pelvis supports the body weight and protects the structures within the pelvis, the bladder, rectum, and female reproductive organs. The pelvic girdle is formed by the ischium, ilium, and pubis. Okay, and do we have a picture of this? No? I thought I put one in here. It's okay. So the ilium's the top part, the ischium's more of like this, the center area, and the pubis is the connection between the two. Okay? Lower extremity, these are all fair game things I need you to know. Okay, so the pelvis is actually the hip bone. It's the iliac crest right here, right? And then so here is the femur that joins into the pelvis right here. And so when someone says I broke my hip, we're going to talk about this. They typically break it right here. Okay, and so this is called the neck of the femur. They break their hip right here. Okay, and so but it's technically a proximal femur fracture. Okay. And so I think if I were to say put your hands on your hips, you're going to put your hands on your pelvis. But really the hip is referring to this little beginning of the femur right here, okay? And so this is the femur. It's the longest bone in the body, largest bone in the body, okay? And then at the right here, at the end of the femur, there's a little cap, and that's called the kneecap. This is an independent bone. The medical word for the kneecap is called the patella, okay? Down here you have the tibia. This is the big bone. This is the shin bone, okay? And then this bone, if you just remember that the fibula is small, and so if sometimes you might tell a small fib, a small lie, you're just fibbing just a little bit. And so if you get confused between the two, remember that the fibula is the smaller one that's kind of just telling a lie. And so the fibula is smaller than the tibia. The tibia is the big shin bone. Okay, that's the one that you can feel a lot easier. Okay. Down here we have the ankle and so the bones that make up the bones that make up the ankle are like the tarsals and and then the metatarsals are more so the foot bones themselves, and then the phalanges, again, just like the fingers, are the digits, right? So these would be the toes. Okay. And so this is looking at a sideways or like a lateral view of the foot. And so this is the Achilles tendon. This is the tendon that joins your gastrocnemius with the calcaneus. Okay. And so this is like the heel. You can feel this. This is the heel of a foot. Okay. The tibia comes down. The majority of weight, actually almost all weight bearing is done with the tibia itself, not with the fibula. Okay. Again, that's another reason the fibula is kind of a liar because it's not taking a lot of weight. It's really the tibia that's taking the majority of the weight. Okay, and doing the majority of weight bearing. Okay, so the calcaneus, these are all metatarsals. Exactly, their exact names are not important at this point in our training. And then the phalanges. Okay, the phalanges are, again, digits. So what are on these pictures are fair game. Everything on here you need to know, and we're going to ask you about these in class, and we're going to do some projects to make sure that we're good with bones, because these are the ones that are tested. We're not going to ask you about individual metacarpal, carpal, metatarsal, tarsal bones, right? Joints like that. We don't need to know those, but the major ones that are on these slides are fair game for exams and in class. These are pretty basic ones that really you probably already know, but just be aware these are fair game. So if there's one of these you don't know, I'm telling you now, you do need to know this for the upcoming quizzes and exams and in class. The bones of the skeleton provide a framework to which the muscles and tendons are attached. We've said that. A joint is formed whenever two bones come into contact. And so usually these are held together by a capsule, a fibrous capsule. And then the fluid, when these rub together, is called synovial fluid, okay? And so synovial fluid is the lubricant that's in a joint that provides lubrication and a little bit of cushioning. And so when you have a joint, this allows motion, okay? And so in terms of fractures and locations, typically these will happen from a direct blow, right? From like, again, a baseball bat to the arm, from an indirect blow. So this can be like trauma that's indirect, like reaching on and grabbing onto something, right? That could be it. Twisting forces. You see this a lot in pediatrics when someone will pick up a kid by their arm and yank them, right? With a twist. And so you can twist up the arm. This can also happen in machinery. You can obviously twist up an arm or a leg pretty well in machinery. And high energy forces. What's a high energy force? Like a gunshot wound. Okay, that's high energy. And so a fracture is defined as a break in the continuity of a bone. And so just like we were talking about all these open close things, it's what it sounds like. An open fracture is when there has been an open of the skin. Okay, and so one thing to point out is anytime there's an open fracture, it's a very big deal. The patient has to go to the operating room and they have to undergo debridement, and usually they'll set the bone back. Okay, and so just be aware that yes, bones can stick out of the skin, and when you arrive on scene of the 911 call, it could still be sticking out. But a lot of times it'll poke out and come right back into the skin, to where anytime you have a break of the skin with a fracture, that is considered an open fracture. The bone does not have to be actively sticking out to be considered an open fracture. So I'll say that again. This is important and a little confusing. Anytime you have a fracture and there has been at any point a break in the skin, it is considered an open fracture. Okay? So watch out for that. The bone does not necessarily have to be sticking out of the skin when you arrive. Can it be doing that? Yes, that's still an open fracture. But even if the bone was stuck out and it stuck back in before you got there, and there's no visible bone sticking out of this fracture, but there's a hole in the skin or a laceration in the skin, it's considered an open fracture. That is a very big deal. When that happens for patients, they have to go to the operating room. Always. Now, you're going to determine whether the overlying skin is damaged, and again, treat any injury that breaks the skin as a possible open fracture. Cannot stress that enough. Fractures are described by whether the bone is moved from its normal position. A non-displaced fracture is a simple crack of the bone. Okay, and so displacement's talking about it's out of place. Okay, and so you could just, snap a bone and put it back together. It's still snapped, but it's back where it was originally was. That's called a non-displaced fracture. A displaced fracture is when there's actual deformity or distortion of the limb. I should have went to Dollar Tree and bought some pencils or something. That would have been fun to break some pencils to demonstrate my point, but I didn't think of that, did I? So, okay, you'll just have to use your imagination. Now, these are talking about some different fractures. We're going to cover these specifically, but we'll just lay out some ideas. And so, if you've ever had to break a tree limb that's living, it's not like if you just take one straight off a tree and try to break it, it's called a green stick, right? And it's because the reason when it breaks, it splinters. It doesn't kind of break in half like what you would think. And so that's called a green stick fracture. And so who gets that? Little kids, because their bones are more soft and malleable, okay? An oblique fracture sounds like what it sounds like. It's at an oblique angle, okay? A pathological fracture, these are the fractures that happen because of underlying pathology, usually in the form of bone cancer or osteoporosis, stuff like that. An incomplete fracture is what it sounds like. It's a fracture that did not completely go all the way through. Okay, you can see that here. There's a little bit of, it didn't go all the way through. And so There's a few more terminologies we need to know. Comminuted. A comminuted fracture is when a bone is broken in more than two fragments. And this one right here is a comminuted fracture. Okay. You see how there's like little, so it's broken here. This bone is broken in here and here. It's broken here, right? And so basically the bone is in more than one piece. Okay. And so anytime a bone is just like kind of piece like chunked up like that, where there's chunks missing, or it could be like a chunk here that's missing, that's called comminuted. And the reason that's important is because usually you'll have to go into surgical hardware and fix it that way. You can't just like splint this together and hope that it'll heal back. Usually you have to go and screw that back in with plates and screws. Now, an epiphyseal fracture is a fracture of the growth plate. So the epiphyseal plate is a plate usually at the top of the bone. So let's imagine it's here in a kid that will grow. This is where bone growth takes place and longitudinal expansion takes place. And so the reason this becomes important is if you break the bone right here in a kid, the reason this becomes important is because the child will have stunted growth in that extremity. And so it's kind of a big deal when this happens, when someone breaks their growth plate. And so this will happen in children pre-puberty or in puberty even, right? But post-puberty, it doesn't matter because you've already done your height growth. But pre-puberty, this is a big issue if you break a bone on the epiphyseal plate area, because that area may not grow properly when it's healing or even after it's healed. Again, a green stick is an incomplete fracture that passes only part way through the shaft of a bone. And so again, you can imagine like trying to break a green branch off of a tree. It doesn't completely break in half all nice and perfect. It'll kind of splinter, and sometimes it won't even completely break. An incomplete fracture is a fracture that does not run completely through the bone. That's what it sounds like, right? An oblique fracture is at an angle across the bone. And a pathological fracture is from a weakness or diseased bone, okay? And so this is usually from like, you could get this from Paget's disease, osteopetrosis, osteoporosis, bone cancers. These are all reasons you can get a pathological fracture. These are the patients that are laying in bed and all they did was roll from their left side to the right side and they snapped their femur in half, right? That's these people. That's a pathological fracture. A spiral fracture is what it sounds like, and that's going to be C, right? Yeah, C is this choice right here. So it sounds like it's in a twisting force, okay? A transverse fracture means it's just straight across the bone. This is kind of what you would think of when you think of a broken bone, because it just goes straight across. That's a transverse fracture. Okay, so do know these. I wouldn't be surprised if you got a test question or a quiz question where they're just going to say they're going to either have a picture or they're just going to show you one of these and you're going to have to figure it out what it is. Okay. And so suspect a fracture if one or more of the following signs is present. And so deformity, tenderness, guarding, and swelling. And so this leg does not take x-ray vision to figure out, wow, that doesn't look normal. That's supposed to be straight and it's not. That's a deformity. That's what we would call an obvious deformity, okay? And so there's obvious deformity to this. Notice the leg is shorter than the other leg, okay? The leg is rotated outwards at a very odd angle, and it's angulated, okay? And so these are all things that you see all in this one fracture to where you'd be like, I mean, again, you don't have to be a paramedic or EMT. Like someone in Walmart could walk up at that and be like, yeah, that looks broken, right? And so it is very obviously broken, okay? It's an obvious deformity. Now, swelling can occur just because of the inflammatory response because you've injured the body. And also keep in mind, think about it. All of your blood cells are made inside the bones. And so do you think the inside of a bone is vascular? It is. It is very vascular. And so this is one of the things you have to worry about is bones are very, very vascular. So when they get broke, they can bleed a lot and cause a lot of edema. They can cause large hematomas, large amounts of blood loss, compartment syndrome, all of that. Okay. And so a fracture will almost always have bruising. What's the medical word for bruising? Contusions, hematoma. The color is described as ecchymosis. Okay. Or crepitus. I've said this a lot. What's crepitus? It's the sound of two bones rubbing together that are broken. And it's not just the sound, it's also the sensation of two bones rubbing together, okay? False motion, this is when it's moving when it's not supposed to, like something that's moving that shouldn't be moving. Exposed fragments, this would be obvious, pain, or a locked joint. And so now the thing with a locked joint, you can see this in dislocation as well, but we'll talk about that. Now, speaking of dislocations, a dislocation is when the joints in which the bone end are no longer in contact. So one thing I want you to know about dislocations as a general rule is this happens in young people. So I'm saying like less than 55, typically younger people, okay? Less than 50, 55. It is astronomically rare for an 80-year-old lady to dislocate something. Why is that? It is easier for her brittle bones to just break than to just separate at the joints and pull apart. So this is why young people, their bones are so strong and that it's easier for their joints to give instead of their bones to give. And so they will dislocate them at the joints because the joints are relatively weaker than the bone. Okay. And so again, dislocations are a disorder of young people. What does that mean? If they tell you a 22-year-old male has shortening in internal rotation or external rotation of the right leg, you should think, oh, that sounds like it's dislocated. We're going to talk about that instead of thinking that sounds broken. But if they give you the same scenario, 82-year-old lady has shortening in external rotation of the right leg, you would think, oh, that's a broken hip. She broke her hip, okay? And so that's an important thing to note, that dislocations happen in young people. So sometimes a dislocated joint will spontaneously reduce, okay? And so reduction is where the joint will pop back to where it's supposed to be, okay? Now, you may have seen these weirdos that will like pop their shoulder out and they're like, oh, just pop, and they'll like pop it back in. It sicks me out when they do that. But if your shoulder's always dislocating, I get why you would do that, but it's just kind of, it's not my thing. It's my ick. Like, it's gross. And so sometimes a dislocated joint will spontaneously reduce. Confirm the dislocation with the patient history. Okay, something to know. Let's just say right here. You have to imagine there's tendons that are normally connecting all of this together, okay? And so when you dislocate a joint, these tendons are being stretched. And so that causes severe pain, but it's stretching something that used to be very, very tight. And so as you continue to stretch this out, what that means is when this goes back into place, the joint, the tendons and ligaments, remember, tendons connect muscles to bone and ligaments connect bone to bone. What's happening is these are all stretched out now because they've had a prior dislocation. So that means that next time they do this same offending activity, playing basketball, whatever, swinging a bat, and they dislocate their arm again, it's because these tendons are loose. They're not as tight as they once were. And so what does that mean? That means people that have dislocations have a history of dislocations usually, okay? Because they're going to continue to dislocate that same joint over and over again. Again, this is why the people that like dislocate their shoulder, they know it's dislocated, they know how to get it back in, and they know it's probably going to happen again because the joints have gotten loose. Now, a dislocation that does not reduce back into place is a serious problem. And why is that? Again, you're stretching out the tendons and ligaments. That's an issue, but not an extreme emergency. But you could also be restricting the blood supply or damaging the nerve, okay? And so those are all things you have to think about with a dislocation. Or really any fracture, but especially a dislocation. And so this is an obvious deformity, okay? And so this looks like it's been dislocated. This has been dislocated. You can see it's not in its joint space. This one has been medially dislocated. This one is very obviously dislocated. Okay, this is the knee, this is the elbow, this is the shoulder. And so the signs of and symptoms of a of a dislocation is going to be deformity, like that. It's obviously deformed. Okay, swelling, pain that is aggravated with any attempt at movement. So basically, if you were to just barely try to move this, it's going to be so tight because those tendons and ligaments are being pulled so tight, it's going to cause extreme pain. Okay, they're not going to want to let you to move that because it's going to hurt so bad. Okay, loss of normal joint motion, that's intuitive, and numbness or impaired circulation. Why numbness? Right? Why would the joint be numb? Because the nerve has been compromised. Why impaired circulation? Because the arteries and veins have been compromised. Okay. So those are all things to consider. This is why if they don't reduce, they become a serious problem. Now that's dislocations. Now sprain is different. So this occurs when there's twisting, when the joint itself is twisted or stretched beyond its normal range of motion. And so a sprain um, can be mild to severe. You may have sprained your ankle before playing soccer or something like that. But some of the more vulnerable joints is going to be the knee, shoulder, and especially the ankle. Okay. And so severe deformity does not typically occur. And the reason that is because a sprain is not a dislocation. This is when things get stretched out, but they don't necessarily fall out of the joint. The joint space doesn't necessarily get pulled out of the wrong area. Okay, like a dislocation. So remember, in a dislocation, you will have deformity. D for deformity for dislocations. But a sprain, it typically will not be grossly deformed. Now, with the sprain, what it will be is it will hurt. Okay, and the reason this is you have temporarily stretched things further than they were supposed to go. You've hurt it, and so you'll have guarding, which means they're not going to want to let you touch it. Okay, swelling and ecchymosis. What's ecchymosis? What's ecchymosis for the thousandth time, right? That's the color of a bruise. So this has ecchymosis. We'd say there's ecchymosis to the lateral portion of the right foot. Okay, that's the patient's right foot. Okay, the lateral portion. And then pain and instability of the joint. Again, when you sprain something, you're temporarily stretching out those tendons and ligaments. And so what they're going to do is when they walk on it, they're going to feel unstable because those have been stretched out. And so that joint is not as tight as it once was. And not only that, it's very painful. And so just keep that in mind. So watch out for the word joint instability. That means sprain. As opposed to a strain is a sprain is a joint issue. A strain is a muscle issue, okay? And so a strain is like if you strain your neck or if you strain, I don't know, your back. You see this a lot in back strain, okay? And so this is a muscle issue, okay? And so we won't do that. So it causes a stretching or tearing of the muscle is a strain, okay? Very painful. It can cause swelling and bruising underneath the soft tissue of the area. Why is that? If you have torn or stretched a muscle, what's inside of muscles? Blood supply. So you'll usually end up with bruising underneath this, okay? Often no deformity is present and only minor swelling is noted at the site of injury. Now, an amputation is we've covered this. It's what it sounds like. The leg has been, or the extremity or the finger or the toe or whatever has been completely removed, completely severed. Now, what's it called when it's only partially severed, right? So the leg is just dangling by some skin. That's called a partial amputation. Now, it can damage every aspect of the musculoskeletal system, right? So this is going to be the skin, the muscle, the nerve, the bone, the blood supply. Everything's going to get, obviously, it's going to get severed, okay? And so the complications or orthopedic injuries can lead to systemic changes or illness. The likelihood of having a complication is related to how much force was applied to cause the injury. Where is the injury located? Again, you're going to have a different outcome with a broken foot broken toe versus a broken pelvis. And the patient's overall health, right? The 66-year-old male who's on his fifth heart attack, who smokes 3 packs of cigarettes a day, who's an alcoholic, right? And a type 1 diabetic, he's not going to do well with a fracture. But someone like you, a young individual who's healthy and takes good care of yourself, I hope, is going to have a lot better outcome with the same broken pelvis, okay? And so obviously the patient's overall health and really activity level before and after the fracture can play a role into this. And so if you have an open fracture to prevent contamination, remember, what's an open fracture? This is any time you have a opening of the skin with an underlying fracture. Does the bone have to be sticking out? No, it does not. It just has to have an open skin around a fracture area, okay? And so let's say you have a motorcycle rider and, or a dirt bike rider, let's say that. And so he did his big jump, but he snapped both his femurs, so he has bilateral open femur fractures. So his legs are completely covered in dirt. What are we going to do? Just wrap it up with the dirt in it? No. You're going to brush away any debris, okay? And so don't enter or probe or stick your finger in or stick anything into a fracture site. Remember, that's obvious, but the reason this becomes contamination becomes a concern is because it's really, really hard to get rid of infection of the bone once it's there. And so if you get like normal skin flora, staph epidermidis or Staph aureus on the joint space or on a bone, it is a really, really, really big deal, and it's really hard to get rid of. Okay, and so it can be late, it can be fatal, and so that's something to keep in mind. This is why, that's what I'm telling you. Any patient that has an open fracture, they have to go to the OR for debridement and to reset it. Because and debridement means to clean it because it's that big of a deal, the whole open joint stuff. I mean, open fracture stuff. So uh, you can help reduce. So remember, primary injuries already occurred. We're preventing secondary injuries. So you can help reduce the risk of and duration of long-term disability by preventing further injury. So we're preventing secondary injury, reducing the risk of wound infection, minimizing pain by the use of cold and analgesics, right? So as paramedics, we give these patients fentanyl, morphine, Dilaudid, ketamine, right? So we load them up with some liquid margaritas to help treat their pain because these patients hurt a lot. And I will make it rain narcotics on these patients because it hurts, right? This is where the narcotics save the day. Like these patients hurt a lot. Not only that, when you're transporting on the back of an F450 ambulance, right? It's very bouncy, it's very rigid. And so it hurts even more when you're moving them and putting them on the stretcher and all that. And so just keep that in mind. And so we transport them to an appropriate medical facility. So there is the golden hour. It's critical for life and for preserving limb viability. It basically says if you can get a patient who sustains major trauma to a hospital within the first hour to definitive care, they have a better outcome. And so that sounds intuitive, right? The ones that get to the hospital the quickest tend to do better. Okay, shocker. But prolonged hypoperfusion, which can cause significant damage. So that's saying prolonged shock. Hypoperfusion is the word for shock, can cause significant damage. And so any suspected open fracture or vascular injury is a critical emergency. And so remember, open fractures are always going to the OR. In a vascular injury, this is where we have to worry about the blood supply has been compromised. And so maybe the area distal to the injury of the vascular injury is not being perfused, it's not getting blood. And so that area could become necrotic and die, okay? And or compartment syndrome, and or have nerve damage, right? So these are all things you have to think about. Now, I will say, interestingly, I would say that most fractures are not critical. Meaning, yes, if you break your pelvis or femur, that's a big deal. But that's not what most people are breaking. They're breaking their hip, they're breaking their hand, their wrist, their fingers, right? Their clavicle, their ribs. So generally, a broken something isn't like life-threatening, license sirens to the hospital. The exception to that, I would say, is the pelvis and the skull in the vertebra. So, with these can be overwhelming, especially because of the patient's pain. I've found myself on calls getting sucked into the patient's pain. What does that mean? That means that like they're hurting so bad, I felt so bad for them that I almost felt like the empathy in me was like, wow, this is terrible. I want to help, I want to help, I want to help. Instead of just taking a step back and be like, you know what? The patient is in pain. I'm giving them all the pain medicine I'm allowed to give them. I'm helping them. This is not my emergency. So just be aware of that these can be overwhelming because of the patient's pain and seeing the deformity, okay? The empathy, sympathy in you will sometimes take it too far. So realize it's not your emergency. You did not cause this injury. We're simply there to help and be good people, good EMTs and paramedics. So just be careful with that. Severe injuries may compromise the neurovascular function. We've talked about this, which would be limb threatening. And so obviously, if you cut off the blood and eventually nerve supply of a leg or an extremity or any type of fracture, you risk the disability that's associated with that. Whoops, where did I go? All right. Make sure the scene's safe, use standard precautions, assess the MOI, have a high index of suspicion, determine if you need additional help, consider that there may be hidden bleeding. And so the same thing could be said, right? If someone has a broken femur, you can lose a liter of blood in each leg, in the thigh, okay? And so that's a lot of blood. That's an entire Evian water bottle, right? And so you would lose a fifth of your blood into the thigh, and so the patient could go into shock. So be aware that you could bleed from a fracture internally that's hidden. Look for the MOI, NOI, right? So look for indicators of the MOI. Be alert for both primary and secondary injuries, okay? What's the primary injury? This is the one that occurred before 911 was called. What's the secondary injury? These are the things that happen after the injury. So homeboy breaks his femur, right? These muscles, so that's already happened. And then when we get there and we start doing goober stuff we're not supposed to do, and we start rubbing those ends of the joints together or the broken bone together, causing crepitus, and now you, in the process of that, you just sever their artery, right? Their femoral artery, and so now they're bleeding into their thigh. That's an example of a secondary injury that we can prevent through splinting and through caution and good care. Okay. So we do our primary assessment. This is the across the room assessment, right? Or this is the after the across the room, right? That's your general impression is your across the room assessment. But this is your first assessment to where you would manage the life threats. Remember the XABCDEs. So if someone has a, open tib-fib fracture and they're pouring blood, what do? We put on a tourniquet, all right? We stop the bleeding. So just keep that in mind. Address bleeding and treat for shock. Check for responsiveness using the AVPU scale and ask about the chief complaint. Now, you might have, oxygen has a slight analgesic property. It's certainly soothing for patients. And so you could administer a high flow oxygen to all patients whose level of consciousness is less than alert and oriented. Okay, why is that? Why would you want to give it to patients that are less than alert and oriented? Right? It's because the brain is very perfusion dependent, and if it does not get what it needs in the form of oxygen and glucose, it stops working the way it's supposed to work, so they have a decreased level of consciousness. They're not as alert and oriented, okay? Now, what are the alert and oriented questions? There's 4, right? Person, place, time, and event. So, what's your name? Person, where are you at? Place, time, what is today? Okay, sometimes I don't know what today is. It's April 7th, okay? And so, sometimes you have to give a little grace on that. So sometimes I'll say, what holiday did we just celebrate? Oh, it's Easter, okay? And then so an event. Now this is where it gets spicy. A lot of people will say, well, who's the president? I don't like that question. It pisses off about half the country about half the time. And so what I prefer just to say, can you tell me what's happening today? And or in your own words, tell me what happened today. If they can tell me that, right, then they're alert to the event. But Barack Obama is the president for 8 years. George Bush is the president for 8 years. And so when a president is a president for 8 years, or even 4 years, right? Trump was for 4 years. Biden's 4 years. And so Clinton 4 years. And so, well, 4-ish. So just keep in mind that this becomes like 4 years is not a current event. Anyways, airway and breathing. Fractures and sprains usually do not create airway and breathing problems. That's true. Yeah. With the exception of that would be what, right? Fractures to the face. Evaluate the chief complaint MOI. And so what we always want to do is, just like when we put on a backboard, we always check pulse, motor, and sensation of the affected extremity that we're about to splint before and after our interventions. We will cover this in depth in class. But one of the ways we do this is we need to make sure the patient has a pulse. And so what we'll do is we will take the patient and we will have to find their pulse. And so on me, this is rather easy, but on an obese patient or a patient who's critically ill, this is not easy. So what we'll do sometimes is we'll fill, right, and not with a highlighter, but with like a Sharpie, and wherever I felt it, I'll put an X on it. That way I don't have to like feel around to find where the pulse is at. I'll just be like, oh, it's right there. It's where X marks the spot. And so this becomes helpful in like the dorsal pedis artery or the pedal artery, right? Pedal pulse, or the posterior tibial artery or the medial malleolus artery or whatever. It becomes easier to find your spot. So what I'm saying is someone broke their ankle and you need to check pulse points proximal or distal and proximal to that. So I would mark the popliteal artery and I would mark the pedal pulse, okay, with where those are at to make it easier. So now the reason we check circulation in these extremities because you worry about the fact that circulation has been compromised and the vessels have been injured potentially. And so one of the signs of a vesseled injury would be skin that is pale, cool, and clammy, or a delayed cap refill, right? And so especially in one extremity, what does that mean? That means, you look in the patient's, let's say they broke bilateral, or they broke their right humerus. They broke their right humerus. And on this side, cap refill is 9 seconds. But then when I check it on the unaffected side, it's 2 seconds. That tells you that it's not a systemic issue. That is a right arm issue, okay? And so it is good to check these bilaterally. So when I'm feeling for a patient's pedal pulses, let's say they have a right ankle fracture, I find the pedal pulse on both sides and I mark it on both sides. Okay, you should have it on both sides. Now, if you have an absent pedal pulse in both feet, they may have peripheral artery disease. Okay, so we can't definitively say, oh, this is from the fracture. And so this is why it's important to compare it to both sides, because you don't, you know, if you walk into the ER and say, oh my God, we have an ankle fracture and they don't have a pulse, right? Maybe you just suck at finding pulses, one, or two, they have peripheral artery disease. They haven't had a pulse there in 2 years, right? A pulse strong enough to palpate. And so that's why it's important to check a pulse in bilateral sides, okay? Check cap refill in bilateral sides. Do a skin assessment in bilateral sides. Check for swelling in bilateral sides of the body, okay? And so, the same thing. If you were to look at some old lady's knees, you would think, wow, that's really swollen. But you compare it to her unaffected knee that she's not having pain in, and it's equally swollen. She just has big fat knees. And so this is why when you're assessing orthopedic injuries, all God gave us, we're bilateral, right? You have two sides. So what you can do is look for symmetry on both sides. Does this side look like the other side? And then that is our comparison. So we say, oh wow, the right knee is about twice the size of the left knee, right? The right knee is the size of a basketball and the left knee is the size of a softball, right? And so these are things that you would use in your report and in your documentation to further articulate what is that you saw and what you observed. So transport decision, provide rapid transport if the patient has an airway or breathing problem or significant bleeding. Again, this is rare in most orthopedic injuries, but it is a possibility. Now, the thing about the rapid thing is people get careless when they get rapid. So rapid does not mean chaotic. Rapid does not mean without care. So still be careful and don't be bouncing the patient around and stuff like that. A patient who has a significant MOI but whose condition appears stable should be transported promptly. Patients with a simple MOI may be further assessed on scene. I think there's very few times where this is necessary, but if they're very, very simple, then you can. Okay, I'm more of a let's go to the hospital type of guy, if you haven't caught on. History taking, obtain a medical history and be alert for injury-specific signs and symptoms and any pertinent negatives. Again, what are pertinent negatives? These are the things that are not there. Okay, so the patient has, I don't know, the patient has pain in the right foot, but there is no swelling, there is no bruising, right? And so that's a pertinent negative to say, yes, there is not. It's negative for the fact that they do not have swelling, they do not have bruising. But it's so that you're reporting the positive, yes, there's pain in the right foot, but there is not swelling or bruising, okay? A significant trauma has occurred, you would start with a secondary assessment of the entire body. So isolated fall or an isolated finger injury, like a broken finger, they got hit with a hammer, probably don't need to do a full head to toe exam. But, if someone was in a car wreck and they had broken fingers, then yes, you would need to do a full head to toe exam, okay? Begin at the head and work down systematically. We'll show you this in patient assessment. We'll continue to perfect this with scenarios. When lacerations are present in extremity, consider an open fracture. Remember, lacerations, punctures, anything like that, any break in the skin, you have to think this is an open fracture. Any injury or deformity of the bone may be associated with vessel and nerve injury, okay? Remember the 6 Ps, which I have no clue what those are. So let me know. I don't know. What are the 6 Ps? Pain, pallor, palpation? I don't know. I'm not looking it up. So obtain a baseline set of vital signs. Now repeat the primary assessment every 5 minutes for unstable patients, every 15 minutes for a stable patient. Assess the overall condition, stabilize the XABCDEs, right, and control any serious bleeding. In a critical injured patient, secure the patient to a long backboard and transport. So there's actually an important story about this. There was a guy who used to be his name is Steve Gifford, and the reason I'm telling you the story is I was told this by literally both of my paramedic EMT, or my advanced EMT and my paramedic instructors at 2 different schools. And so basically this guy was at Possum Kingdom and he took a jet ski to the chest, right? He was on a lake, took a jet ski to the chest, broke a lot of bones, right? So he's critically injured. And the crew that was there in the water, and on the boat are trying to splint every single one of his fractures, right? And so this is taking a really long time to just get him to the land to where you can get him to an ambulance, get him to the helicopter. And so the lesson learned there was this guy bled to death while people were messing with extremity fractures, doing useless garbage, right? And this guy died. He was probably going to die anyways, unfortunately, but he died because of this. And so the lesson of this is when people have a bunch of broken bones, the backboard becomes the splint, right? So you put them on a backboard and that's the splint. And I've had this happen where they're so banged up and busted, I didn't splint anything. I put them on a backboard and strapped them down, and that was their splint. I had other things to worry about, like their shock, their airway, okay? And so you'll see this in multi-system traumas where people have a lot of broken bones. And at that point, we don't start applying a SAM splint to everything that we can find. We just put them on a backboard and go to the hospital, okay? If the patient has no life-threatening injuries, take extra time at the scene to stabilize his or her condition, okay? And the reason this is one of the few times I'll say in play, is just because you want to get that bone splinted and comfortable before you start beat bopping down the road in an ambulance. It hurts. It hurts to bounce down the road with broken bones. And so the main goal is stabilization and the most comfortable position that allows for maintenance of good circulation distal to the injury. And so the idea is to make the patient comfortable. And a lot of times what will happen, okay, this is what happens with fractures. Almost always, if the patient's conscious and capable, they're going to do this. So you're going to find old lady falls in the Walmart, and then boom, 911's called. Let's say she breaks her arm. Or let's just say she breaks her arm. And what's going to happen is between the time the primary injury and the time you get there, she's usually going to shift this extremity into an area that hurts less, also known as a position of comfort. And so the thing is, a position of comfort is usually going to realign the bones or at least take tension off of those tissues. And so the patient will almost always self-splint. They will almost always have this in a position, if they're capable of comfort by the time you arrive. Okay. And so the thing is, if it's in a position of comfort, usually they have good circulation as well, because if you don't have good circulation, that hurts. Okay. And so that's something to keep in mind, that a lot of times when you get there, the position you find them in is their position of comfort. So honor that. You'll see this with broken clavicles. You'll arrive up on scene to the baseball or the football practice, and the kid's holding his arm like this across his chest, right? And so it's because this is where people hold their broken clavicle in a position of comfort. Okay. Now, communication documentation, include a description of the problems found during your assessment, right? Report problems with the ABCs, open fractures, and compromised circulation, if any. This is where cap refill, saying, oh, capillary refill was 6 seconds prior to splinting. After splinting, we noticed it was less than 2 seconds. You have resolved their neurovascular compromise by splinting it. And so this is a treatment of splinting, is to put it back where it's supposed to go, to where these nerves and vessels are not occluded. And so perform the emergency care, perform a primary assessment, stabilize the XABCDEs, perform a secondary assessment of either the entire body or the specific area of injury. Use your judgment when that's appropriate. In isolated injuries, you don't necessarily have to do a full body exam. Follow standard precautions and be alert for internal bleeding. And so before we get into splinting and the actual ones, I think I'm going to make this 2 videos, because we're going to do questions at the end. We have those 10 questions at the end. So I'm going to pause here, and then we're going to have another video for the second half of this.